Hello, I'm Keith Orbath, and thank you for attending this STS Advocacy Conference. Let's talk for a moment about the Resident Physician Shortage Reduction Act. This bill has had a lot of bipartisan support, and in the Senate it is supported by Chuck Schumer, Robert Menendez, and John Boozman. In the House, Terry Sewell, John Katko, Tom Suozzi, and Rodney Davis. So with that bipartisan support, it should be a relatively easy ask to get your representative or senator to also co-sponsor this bill. But why? Why do we need this bill enacted? Well, there are a number of reasons, but let's start with what this bill primarily addresses, and that is graduate medical education. As you may know, GME is largely funded by Medicare, hence the involvement of Congress and the federal government. But it is also funded by Medicaid, private payers, the Veterans Administration, and other state and federal programs. And this investment has long been understood as a benefit to society to have a skilled physician workforce, hence the government subsidization. So, adequate GME funding is essential to training this workforce that would meet the needs of our population. But why is this a problem? Seems like this has been in place for a while, but what has changed is that the population has grown and the number of GME positions and the funding for GME in particular has not grown to match that. And in fact, there's projected to be a shortage of between 54,000 and 140,000 physicians by 2033. And this also includes a shortage of surgeons, between 15 and 30,000 of surgical specialists. In short, this is driven by many factors. There is the aging population and as well the physicians that are aging and retiring. There is this outdated cap on the number of resident positions. This cap was put in place in 1996, and that number has not changed over several decades. And as well, even if there had been some increases in the number of GME positions, there still is a significant maldistribution of specialists that this act would help address. So the important features of this are that there has been an attempt to address this shortage at the UME level, specifically increasing the number of med schools and therefore the number of med school graduates. And that has occurred. There's been a 30% increase since 2003, but there has not been a concomitant increase in the number of GME positions. So we need this act to be instituted and made into law to allow this expansion of residency training to match the expansion that we've seen in undergraduate medical education. So there have been some recent events that have been heartening because this type of Physician Reduction Act has been in place, or has been proposed, I should say, since 2007 on basically an annual basis. Why is the ask important now? Well, we've had a little bit of a breakthrough with regard to Medicare-supported GME positions. In December of 2020, Congress increased this number for the first time in 25 years, and they added 1,000 positions. Now that's 1,000 positions spread over several years, and they're very, very specialized as to who is able to obtain these positions, what institutions are likely to be able to get an increase in the number of GME positions that they have. But this still, nevertheless, was groundbreaking in that there had been no increases in GME positions, as mentioned, for several decades. So this particular act then builds on this and would increase the Medicare-supported GME positions by 14,000 over 7 years. Again, won't solve the overall projected shortage of physicians, but it certainly will help, and therefore is important for us to take the opportunity now to get this act converted into law. So specifically, what's in this bill? As mentioned, 14,000 new Medicare-supported residency positions over 7 years. It sets criteria for allocating new GME positions, again, something that probably has needed to be addressed over time. And it requires the new GME positions be funded in line with current Medicare reimbursement levels, allows the qualifying hospitals to receive up to 75 new GME positions per year over this 7-year period, and does require the Government Accountability Office to conduct a study on increasing the health professional workforce diversity. So this is important for a number of reasons. CMS is required to consider the likelihood of a hospital filling that position and must divide at least 10% of the slots to each of the following categories: hospitals in rural areas, hospitals training over their GME cap, hospitals in states with new medical schools or branch campuses, hospitals that serve areas as designated professional shortages, and it also requires hospitals to increase the number of residents' full-time equivalent positions by the number of slots awarded. This is important as it prevents a hospital from swapping a slot that is not supported by Medicare with one that is. So all of these are critical pieces of the bill that, while sound somewhat limiting, the bottom line is it will increase the number of positions funded, which is essential for the increase of our workforce and, in fact, the sustainability of our workforce. So, as mentioned, it has broad bipartisan support. In the previous Congress, it had 222 co-sponsors, including 189 Democrats and 33 Republicans in the House, and in the Senate, 15 Democrats and 2 Republicans. So in the shadow of the pandemic, however, this has become even more important. And the fact that we are continuing to grapple with the current shortages of physicians, and it's only going to get worse. So this provides an increase in a number of priorities that not only this administration, but cardiac surgeons in general are in favor of, particularly making sure that the underserved and rural area constituents are that their needs are being met, and that access to cardiothoracic surgical care is also available to all. There really isn't any major opposition to this legislation. That you may hear some discussion of whether government funding for GME slots at appropriate levels is an issue that needs to be addressed. But as we've already reported from the American Association of Medical Colleges, there are 10,000 residency positions receiving no support from Medicare. So the need is there. The institutions are actually, because they are over their caps, are continuing to fund residency education. But that shouldn't be the way that this is funded. It's not the way that it was intended to be funded. So again, it won't solve the workforce shortage, but it is a significant step in the right direction. And without further congressional action, this problem is only going to get worse. The physician pipeline, when you think about it, from college to medical school to residency to being a faculty attending physician, is a long one. And it's going to take many years to overcome the shortage. But we hope that you'll ask your elected official to co-sponsor this really important legislation. Thank you.